We're going to go on to the next chapter, which is neuropharmacology. In the second part of the neuropharmacology lecture, we're going to be discussing cholinergic agonists and anticholinergics. It is the second half of the autonomic nervous system. Last chapter, we talked about the sympathetic nervous system, and this chapter, we're going to talk about the parasympathetic nervous system. The parasympathetic nervous system, remember, is your rest and digest. So we're going to talk about some different parasympathetic agents. The ones that we're going to talk about are the ones that are going to be either ones that block the neurotransmitter, which is acetylcholine, or ones that mimic the acetylcholine. So when we talk about ones that mimic the acetylcholine, we're going to be going through and talking about drugs that are cholinergic drugs, or parasympathomimetics, or cholinergic agonists, or cholinergic stimulants. Now, if we do not want to have the action of the parasympathetic nervous system, we're going to be talking about something that will block the acetylcholine. Those primarily are going to be your anticholinergics. And the anticholinergics are the blockers because they're anti. So the cholinergic system is the rest and digest. Some people also use the acronym SLUD, SLUDD, which is salivation, lacrimation, urination, digestion, and defecation. So it all has to do with the GI tract um, breaking down food, urination, so all those natural bodily functions that we do when we're relaxed. So the cholinergic agonist, or something that is going to be mimicking the cholinergic system, are going to be our parasympathetic responses. So in our cardiovascular system, it's going to see a decrease in our heart rate. It's going to lower our blood pressure due to vasodilation of our vessels. It's going to slow down the conduction between our atria and our ventricles, which also results in the lowered heart rate. Now, in the GI system, we're going to see an increase in tone and mobility of the GI system. It's going to increase motility, so things are going to pass through your GI system. It's going to cause peristalsis to increase, and it's going to relax the GI sphincters. So once stuff is broken down in each section of the GI tract, it will continue through all the way out to defecation. In the urinary tract system, it's going to contract the muscles of the urinary bladder. The bladder is a muscle, and to be able to use the bathroom or to void, that muscle needs to be able to contract to be able to push the fluid out of the bladder and into the urethra so it can be expelled. It also can affect your uterus, and that increases the tone of the uterus, and that's what also happens during labor. It relaxes the sphincters of the bladder, so that way the urine can pass, and therefore it will stimulate urination. In the eyes, it will cause miosis, which is the constriction of the pupils. You don't need a whole lot of light and vision acuity when you're doing resting and digesting. It also, in the glandular, especially the salivary glands, it increases salivation to start the digestion process. It can cause perspiration, and that's sometimes what you see when someone who is eating, especially hot foods or spicy foods, that increases that salivation process, where you can see that eating sweat. It can also cause lacrimation or tearing of the eyes. It also causes bronchial muscles to constrict because we don't need a nice open lungs to get in that extra oxygenation during the sympathetic tone system. It also causes relaxation of the general body and the tone so that it can go through the natural form of rest and digest. Your cholinergic receptor sites are going to be two primary receptor sites. You're going to have your muscarinic and your nicotinic. Your muscarinic is going to be your stimulating your smooth muscles and slow the heart rate. And your nicotinic is your neuromuscular, which go on to your skeletal muscles. And just like in our sympathetic nervous system, you can have direct acting, which basically causes the receptor site to take on the drug and stimulate that receptor site to work in a cholinergic method. Or you could have an indirect, where basically it inhibits the action of cholinesterase. Cholinesterase is an enzyme that goes in and destroys your cholinergic receptor site or acetylcholine. So it prevents that, so you have more acetylcholine floating around to be able to do the proper action. Now, the first drug that we're going to talk about in this chapter is going to be a drug that's affecting the urinary system. Because remember, we talk a lot about the bladder in our rest and digest, our parasympathetic nervous system. This is bethanyl chloride or urochlorine. It is used primarily for what we call a neurogenic bladder, or a bladder that no longer has nerve stimulation, often seen in spinal cord injuries, or for someone who has significant urinary retention. And basically what it does is it goes in and stimulates the cholinergic receptor sites, specifically the muscarinic, and promotes the contraction of the bladder. It promotes that contraction of the bladder. It relaxes the bladder sphincters and allows a person to void. As you see in the picture here in the slide, you'll see that person with a bulging, what looks like stomach, but your stomach is actually higher. That is actually a bladder that is completely filled up, and it's causing such tension in this lower abdomen region that it is causing a distension. And that actually causes quite a bit of pain, cramping, and being uncomfortable. And these patients often have it because they cannot stimulate their own method to start that urination process. As well as trying to treat the urinary retention, it will also cause pupillary constriction and bronchial constriction. It also increases peristalsis, GI secretions, and also it causes salivation. The contraindications are patients who have a urinary tract obstruction, because you do not want to increase that bladder constriction when there is a urinary tract obstruction, because that would be like something pushing against something that's not going to be able to flow. That obstruction needs to be taken care of first, or else it's going to cause a potential rupture of the urethra or the bladder. You also want to be careful with anyone who has severe bradycardia, that can decrease the heart rate, and hypotension because of the fact it slows everything down. The other one would be asthma, because it could increase the risk for a new onset of an asthma attack, wheezing, and bronchial constrictions. So you kind of just need to make sure that you're watching your patients closely when giving a medication like this. Adverse effects. The primary adverse effects that we often see are going to be bradycardia and orthostatic hypotension. The patient might also feel some general weakness as the fact that their blood pressure is dropping and their heart rate is dropping. Our life-threatening ones that we could see is what's called a heart block. A heart block is where your atrias are not talking to your ventricles on a normal pathway. And there's something that's kind of, the signals aren't crossing over. So the atrias contract. That way it can fill up the ventricles contract, and then it either goes to the lungs to get oxygenated or out to the body once oxygenated. So that becomes a heart block, and that could potentially become a serious problem. But in general, what you're going to see and what the patients are going to complain about is our typical nausea, vomiting, diarrhea. It's going to have some abdominal cramping as that bladder constricts so that it can relax the sphincters and release the urine. They're also going to have the other normal side effects, the sweating, the flushing, the salivation. And also, if it doesn't have a good balance between the urinary retention and the amount of medication you're taking, you can also get urinary frequency and urgency. So it's kind of a balancing game to make sure you get the right prescription and the right amount of medication. Patient implications. You always want to make sure you get baseline vital signs of any patient. That's going to have an effect on their heart rate or blood pressure. You also want to make sure that you are assessing their urine output to make sure that they're getting a good quality and quantity of urine coming out, that their abdominal distension is decreased, and that they're not having a lot of residual. You want to monitor the fluids that they come into, and you want to monitor the breath sounds and their liver function tests. Most importantly, you want to monitor for a cholinergic crisis. A cholinergic crisis can cause significant salivation and muscular weakness. And when you have that muscular weakness and increased salivation, you have a risk for aspirating and even to the point where you become minimally functional. So what do you specifically want to tell the patient? You want to tell the patient that they're going to have a high risk for orthostatic hypotension. So they need to change positions slowly and carefully so they don't risk falling. For example, we talked about it in the previous chapter about when we talked about the beta blockers, that they want to move from a lying to a sitting to kind of a dangling, and then upright so they don't have that risk of falling and having a syncopal episodes. And they also need to be made aware that the patient needs to call the doctor or 911 if they have any difficulty in breathing or an acute asthma attack. Okay, let's move to our next drug. Our next drug is going to be nicotine or Nicotrol. Yes, nicotine is considered a drug. Yes, you can buy it over the counter, but you can also buy nicotine as a prescription medication. So when we talk about nicotine or Nicotrol, the whole concept of this, though, is that we're not getting our nicotine through cigarettes, to chewing tobacco, or vaping. We're getting the nicotine in a controlled manner to help the process and tapering out the amount of nicotine and addiction you have or the patient has for smoking cessation. So the whole goal of this is to stop smoking and stop that dependence. It can be, you can get the nicotine or the Nicotrol as a patch, as a nasal spray, or as a gum that you can chew. And basically what they're doing is giving small doses that stimulates the nicotinic receptor sites, and so that way they're getting blocked but not at the constant higher levels, and then you can slowly taper it off. The patient tapers it off so that they do not have that addiction. The most life-threatening adverse effect that we worry about, and the reason why we want to be cautious, are for patients who have any type of dysrhythmias, because those dysrhythmias could then become worse and cause potentially a fatal side effect. Some of the other adverse effects that we see are the tachycardia, headaches, paresthesias, insomnia, nervousness, dry mouth, and these are all the side effects. You can also get nasal irritation if you're using a nasal spray, and you could also have a lot of coughing and irritation. The nursing implication is you want to talk to the patient about the wanting to quit. You want to talk to them if it's an appropriate time to quit. You want to make sure that they are motivated to quit. And you don't want to give it to someone, for example, who's had a recent heart attack or had a recent stroke, or someone that you are worried about that there will be a negative effect for using the nicotine. You want to establish a pattern, and you want to establish an amount to give the patient, and you also want to give them some other ways of dealing with their withdrawal. Because not only are you having the withdrawal from the nicotine, but you're also having the withdrawal from the idea of smoking. For example, if you're trying to get rid of smoking, smoking can be a social atmosphere. And so therefore you're going to also try to work on that so they can get a way of helping themselves with controlling that. And smoking and alcohol often go together. So if they're out at a party and they're drinking, they need to figure out a way to combat that. So you need to give them strategies to help them prevent that. And by having them, not be around people who smoke, or try not to go to parties, or if they're going to drink, stay inside since you can't smoke inside, and different methods to help them conquer that. Just by itself, wearing the patch is not always successful. You also want to teach them how to use the patch if that's what they're doing, rotate sites, and make sure that they keep away from children, because they want to make sure that they don't have the access to the nicotine. The next medication we're going to talk about is neostigmine or prostigmine. This is an indirect acting cholinergic agonist. It is used primarily for myasthenia gravis patients. Myasthenia gravis patients are patients who don't have enough um, acetylcholine, so therefore they often are seeing having a delayed amount and having some negative effects from that, such as facial drooping, decreased ability to catch their breath. They have they eyes water a lot. You can also see urinary retention and a paralytic ileus. The idea is to increase the presence of acetylcholine within the synapse area of the neurotransmitters. So therefore, they can go in and do that transmission and be effective. It's contraindicated for anybody who has a GI or a urinary tract obstruction. That goes back again where you're stimulating the ability to urinate or have digestion. And if you're constantly pushing against something that is blocked, you have a high risk for some type of rupture, whether it's urinary tract or within the GI tract, because both of those have very negative outcomes, including the chance and the risk for infections. Your adverse effects, the most common is going to be nausea, vomiting, diarrhea, and abdominal pain. You're going to also have some meiosis, some diaphoresis, some bradycardia, and potential bronchial spasms. However, you really kind of want people who take this the most often are your myasthenia gravis patients, and they titrate their medication as needed. So if a patient has significant if the patient has like significant myasthenia gravis and they know that they're going to be doing activities that require them to have a higher stress level, they're going to have to take their neostigmine, and they're going to have to take their medication, some extra of their medication, because they want to make sure that they keep their muscle tone effective. Whereas if they don't have enough of their medication on board, they'd be considered having a myasthenic crisis. So, for example, say you were going to go for a hike, which requires you to have more muscle tone, increased breathing, open lungs, and you're going to go for a hike. So, a person with myasthenia gravis would need to take their muscarinic so that they have the amount of medication that they need to be able to keep up with the demands of working out and hiking. So they take their medication so they don't have a muscarinic crisis. So if they take the proper amount, they should have no problems. If they decide halfway through driving to the place that the weather has turned bad and they're not going to be able to go on to this hike now, but they've taken too much of their neostigmine, then they're going to end up going into a cholinergic crisis, meaning they have too much medication on board. So the problem there is they're going to have some bronchial and respiratory spasms going on and constriction going on and increased salivation going on. So therefore, if they don't use that acetylcholine up with the activity level that they're going to do, they're going to be in this cholinergic crisis because they basically overdosed on their medication. Now, the bad thing about a cholinergic crisis and a myasthenic crisis is they look exactly the same. They're going to have increased salivation. They're going to have difficulty breathing, which is the biggest trigger. So you don't know whether a patient necessarily is going to have a cholinergic crisis or a myasthenic crisis. The big thing that you're looking for is you're going to be looking for the different symptoms that you're going to see. For example, in a cholinergic crisis, you can potentially have some abdominal cramping, diarrhea, bradycardia, and increased GI system. You're going to have the pupil constriction and increased salivation and respiratory distress. And the myasthenic crisis, you're going to have muscle weakness that becomes profound and may actually cause a decreasing of your muscle tone. You'll first see it in a drooping eyes, but eventually it can cause shortness of breath and respiratory insufficiency and difficulty swallowing. So they look different, but the bottom line is they both end up with respiratory distress. So if your patient comes in and they know they have myasthenia crisis, and you don't know they have myasthenia gravis, and you don't know whether or not they're in a cholinergic crisis or a myasthenic crisis, what do? The best thing to do actually is to give them some neostigmine. If they get better, you know that they're having a myasthenic crisis. If they continue to get worse, you know they're in a cholinergic crisis, and you give them the antidote. So for nursing implications, you need to make sure you educate the patient on how they're supposed to take the medication properly. You need to make sure that you talk to them about the potentials for respiratory distress and the fact that they need to keep the antidote of the neostigmine on hand. And the antidote is atropine. You want to make sure the patients keep their atropine readily available. So if they do go into a cholinergic crisis, they can give themselves some atropine. And that's what's going to reverse it. It's important that the patient takes the medication throughout the day and evenly throughout the day so that they are not having issues with fluctuations of their ability to swallow, their ability to control their secretions, and their ability to breathe. You also want to make sure the patients know the difference between a cholinergic crisis and a myasthenic crisis. And remember, the myasthenic crisis really often starts out with the drooping of the eyes, and that's where it first goes. But at the end of it, both of them have the life-threatening concept of losing control of the diaphragm. And the next drug that we're going to is your anticholinergics. So it's against your acetylcholine, it's blocking against it. And the primary drug is going to be your atropine. Your atropine is used to control respiratory secretions. We see this a lot in our hospice patients, patients who are dying, who don't have the ability to control the respiratory secretions. And you give them a little oral atropine and it dries them up. You also see it in Parkinson's disease to help control the drooling. You're also going to see it potentially in motion sickness. You can also see it in ophthalmic disorders. They might use it to dilate to dilate your pupils. You can give it for what's called traveler's diarrhea. It's for patients who get anxiety and always having some diarrhea due to the shifting of their diet and how they react to the stress of traveling. It's also used for bradycardia. So if you give a little atropine, it can increase the patient's heart rate. It's also the antidote for someone who takes too much of their muscarinic excess medications, such as neostigmine. So what you're going to see in these patients who are taking an anticholinergic is you're going to see a decreased motility, decreased salivation, dilation of pupils, increased heart rate, and urinary retention. So what we often say is it has the 4 can'ts. They can't see, they can't spit, they can't pee, and they can't poop. They can't see because their eyes are dry and they're extremely dilated, so they get these dry, irritated eyes. They can't spit because they have really bad secretion, really bad dry mouth. They can't pee because they have urinary retention, and they can't poop because everything in the GI system has been slowed down. Contraindications and precautions. Sorry here. Contraindications. Myasthenia gravis. This is going to counteract any medications that the patient who has myasthenia gravis is taking. It's going to counteract all their meds. An acute MI, glaucoma, because it's just going to increase the pressure in the eye. Any type of obstructive GI or urinary tract disorder. An ileus, which basically means that the GI system isn't moving because it's going to make it move even slower. Tachycardia or hypertension, or prostate enlargement. You want to be careful with your COPDers and your cardiac disease patients, and also obviously, as with most medications, your renal and liver disease patients. Again, your most common adverse effects are going to be blurry vision and dry eyes, so you can't see, you can't pee, you can't spit, and you can't poop. Okay, so those are your most common adverse effects. You're going to hear throughout the semester talking about anticholinergic effects. Whenever you hear someone who says, oh, the medication has an anticholinergic side effect, you have to think of these 4 things. Can't see, can't pee, can't spit, can't poop. So if you have an anticholinergic overdose, so this is a person who's taken too much atropine, you're going to see a patient who is mad as a hat, dry as a bone, red as a beet, and blind as a bat, meaning that they're mad because they're so overstimulated that they can't think right. They are so dry that their mouth is dry, they can't pee, they can't poop, their face turns beet red, and they become blind as a bat due to blurred vision and dried eyes. And finally, your nursing implications and patient education for atropine will be always to monitor the patient's CNS effects, change in vision, drowsiness. You want to make sure that they increase their fluids that help with the constipation, as well as increase the fibers. You want to do really good oral care. You want these patients to be constantly brushing their teeth and doing mouth care so that they don't get dry and they don't get thrush. You want to monitor vital signs, and you want to monitor for an anticholinergic overdose. Patient education, you want to make sure if you're giving this to an elderly man that they know that they can initiate their urinary stream, because sometimes with the benign prostate hypertrophy, they have a difficult time initiating a urinary stream or urine stream, and atropine will make that worse. You also want to make sure you tell them about fluids and exercise to help with constipation. You want to make sure that they need to know how the medication affects their eyes before they drive, especially at night. You want to make sure that they have eye drops handy for their eyes so they don't get too dried out. And you can recommend them chewing gum or hard candy so that they can keep their mouth moist so it's not so dry and at risk for decay. So that's the end of our neuropharmacology at this point. So thank you.